just real quickly, I wanted to introduce and describe Dr. Fleming's work to everyone. So really short. Dr. Fleming earned her PhD in rehab from Auburn University and MS in rehabilitation counseling from Boston University. She worked as a rehab counselor for over 15 years in the private sector and the Georgia Vocational Rehabilitation Agency. She moved to Auburn in 2013 to be the executive director of the Center for Disability Research and Policy Studies at Auburn University. She's a clinical assistant professor with the Special Ed Rehabilitation and Counseling Department. So again, we're very honored to have you here with us, Dr. Fleming. And with that, I'll turn it over to you. We can see your slides and we can hear you. And again, just to remind everyone to mute behind you. Thank you.
All right, so if I'm talking now, you all can hear me?
Yes.
Leslie, you did that. Thanks. That was the information I needed. So you can see the slides and you can hear me. Hopefully it won't feel like I'm talking at you. It's always interesting trying to do this without being able to see anybody. But when Leslie asked me to participate in this, I was trying to think what folks would want to hear. So I decided to do the work that I'm doing with the mental health agency here in Alabama, trying to improve the employment outcomes. Let me turn my volume down because I can hear myself echoing in the background. The work that we're doing here with the mental health agency in Alabama. So that's what I'm going to talk to you guys about. I can advance my own slides. So hopefully most of you have already heard about the model of individual placement and support. It's a model of support employment. It's an evidence-based practice that leads to competitive integrated employment. I'll talk a little bit about the funding from SAMHSA that we received here in Alabama, as well as talking about some of the limitations on the availability of IPS. So the research shows that it works, yet it's not available in many states. Those states that are implementing it are having great outcomes, but it's still not readily available. And then we kind of did a survey before we implemented the project here in Alabama to get a sense of what the practitioners thought about it. So we'll talk a little bit about that. And then I just kind of wanted to hit the highlights of kind of the benefit of the integrating of the treatment team with the employment team. So I've advanced the slide already. So I think most of you probably know this. The statistics on the employment of folks with disabilities is really abysmal. And so one of the things we're trying to do is improve those options. So why does it make sense for folks with significant disabilities to go to work? A lot of it makes sense. Most folks with significant disabilities have less resources and live in poverty, primarily due to their need for the insurance, which necessitates them to have limited income. And Leslie, give me the high sign if I'm talking too fast. I have a tendency to talk quickly, especially when I get excited on a topic, which is when I do. Let me know that if I'm going too fast.
Okay, I will. Thank you.
Got a question.
I heard, hold on, I have a question. Is that for me?
All right, it's just we're on the phone back up, and it's a really bad echo. I'm looking in on the state. It looks like if you hit speaker and then turn the mic off, then maybe it will not feedback. I'm going to do that now, but I think there might be some other people that might need to do it.
Can you hear it?
So.
Well, the
yeah, I better now.
If I turn the speaker off of my phone, then you won't be able to hear me at all.
No, if you hit no, I'm talking to everybody else that's on the phone to you.
Oh, gotcha.
If they hit speaker on their phone and then the speaker mic will light up, then if they turn the mic off, then we won't have so much feedback maybe. All right. I'm doing that now.
Shall I begin again?
Okay.
I still hear background noise on the phone. Okay. All right. So Smart in 2009 wrote this wonderful book on disability, and she talks about the biggest obstacle people with significant disabilities, primarily folks with mental illness face, is the stigma attached to it. And so part of the discussion that I looked at was the social role valorization work that Wolfenberger did way back when, talking about the need to move people from devalued social roles into valued social roles, and one of those valued social roles as employment. I still hear an echo. You guys okay? I'll let you guys continue to work on that. Sorry about that. So work is part of the recovery process, and trying to get some of the changing of the mindsets regarding employment. Some people will refer to the stress that's involved in going to work as a deterrent to go to work, but truly when folks go to work, they have improved self-esteem, increased quality of life. One of the wonderful quotes that I like, one of the gentlemen that was assisted with a project here in Alabama, he talked about the fact that he was now able to have ice cream in his freezer like everybody else does because he's gone to work and now has disposable income to purchase that. So I just thought it was a great story to kind of share because it really talks about the importance of going to work. Some of the research shows that there's less dependence on the disability system, less use of mental health services, as well as hospitalization. On our project, we still have not gotten the information on the cost for medical services, but a lot of the other outcomes that WETSTAT's results have shown. It says I've been muted by the host. Can you all still hear me?
Yes, we can hear you.
Okay, just making sure. Let's see. So employment first has kind of been a buzzword that's been out there for a while, trying to get states to start looking at employment as a viable option for folks. But a lot of states don't have IPS employment services as part of that model, and so trying to figure out a way to change those within the system in order to make employment an option for folks. Most people with significant psychiatric disabilities are able to secure employment with the necessary support. They're also able to live independently and be actively involved with their family and friends. Another lady that we helped was homeless and had not seen her children for probably 10 years. And when she went to work for the first time in a long time, she was able to secure housing, and then she was able to visit her daughter and establish that relationship again. So employment really did have a huge significant impact for a lot of folks. All right, so what do we know about employment? So research shows that most people want to go to work, and their wanting to go to work really is the primary indicator of success. So it's not about being without using drugs, with having transportation. It really is that desire to go to work that shows that they have successful employment outcomes. So, however, 60% of individuals diagnosed with SMI indicate that they wanted to go to work, but less than 15% nationwide have access to support and employment services, and of those 15%, it's less than 2% that have access to IPS. So 85% of people with serious mental illness are unemployed. So if they're unemployed and they're dependent upon the disability system, they can expect a life of poverty. And actually, receiving an SSI or SSDI check really lends itself to living below the poverty line. So truly, the only way to turn that around and to escape a life of poverty is to increase their income through employment. So let's look at what is IPS. I don't know how many people that are participating today know what IPS is, but its purpose is to identify the individual strengths of that person, not focusing on what they can't do, but really trying to focus on what they can do. And then through the assistance of an employment specialist, they're obtaining personalized work at competitive wages in an integrated setting. It is an evidence-based practice that leads to successful employment outcomes, but again, as I said a few minutes ago, it's limited in availability. So for those who don't know what IPS, there's 8 principles of IPS. So if we look at those, there's a focus on competitive integrated employment, which basically means real work for real wages at a job that anybody can get in the community and they're working in businesses where a variety of people work, people with and without disabilities. Eligibility is based on consumer choice. The model is zero exclusion, so that if the person indicates an interest in going to work, then they are referred to participate in supported employment, and a requirement of job readiness or sobriety is not there. That may be part of the outcome because they may, in their desire to go to work, stop using drugs in order to secure employment, but it's not an eligibility criterion to prevent them from participating. A third principle is rapid job search. That does not necessarily mean rapid job placement. Part of that rapid job search is getting them informational interviews and talking to employers so that they're hearing from people where they want to work that they need to stop abusing drugs in order to gain employment. And part of that process of working with employers and talking to people to really change those behaviors that need to change in order to secure that type of work. The fourth principle, which I personally think is one of the biggest changes in support employment, is the integration of the mental health team with the employment team. And so it's really having those clinicians meet regularly with the people that are out there looking for employment to kind of work together and strategize what types of jobs make sense for each person. So the fifth principle is that the consumer preference is honored. So it's not about working with an employment specialist who has maybe 10 jobs that are held for someone with a disability, but really trying to identify those jobs that the person wants and only seeking out those employment opportunities based on what that person wants. Number 6 is the individualized job supports. And that really, for supported employment, most folks know that the job coach is present and that those ongoing supports are needed. With IPS, some of the folks that are being assisted may not want the employment specialist to be with them at the workplace, but then those job supports are provided after hours or before work or when it's needed to kind of negotiate the situation. Another big thing is the personalized benefits counseling. For our project, because we had a grant to come through, we were able to hire dedicated benefits specialists that could work with participants throughout the process to help them understand how going to work would impact their benefits. But most states have available benefits counseling so that folks can talk to someone about how going to work will affect their benefits, because it is a big concern, a big fear for a lot of folks that have never worked. And then the 8th principle is developing relationships with employers through multiple in-person visits to understand their business needs, so that it's really taking the time to get to know the employer way before you start negotiating and talking to them about employment for someone in particular, but really trying to take the time to understand their business so that the person that is referred ultimately to the employer is able to really meet the needs of that business. So this slide just hits the highlights. There's lots of research that's been done about the effectiveness of IPS. So the research shows that IPS leads to improved employment outcomes. Now, a lot of their comparison control groups were ongoing mental health services, existing programs that the mental health agencies had available, comparing it to an employment program. But further research is being done comparing an IPS model to other support employment models to see if it's still highly, but with better outcomes. So the majority of IPS participants obtain competitive employment. So that's what prompted us to want to bring IPS to Alabama. So before we implemented the model in Alabama, I did a research study trying to get a sense of what the current clinicians at the 2 pilot sites, what their perceptions were about employment for their consumers. Did they value competitive integrated employment, and what do they currently do around the people that they work with and helping them go to work, and then trying to figure out what was stopping them from considering employment for their consumers. So we did the 2 pilot sites. One was in central Alabama and one was in southern Alabama, and we used the Health Professionals Perceptions of Employment Survey developed by Gladman in Australia. And so we modified the instrument a little bit, but administered it to all the clinicians that were about to participate with the IPS project. So a lot of them valued competitive employment, but really didn't think that the people that they worked with could really go to work. They felt that a lot of their consumers were not interested in pursuing work because they had a fear of losing their disability benefits. They were not certain about work. They also felt that they really wouldn't follow up. They weren't following up with their treatment plans, and so they really weren't ready for employment. However, for those folks who did refer to the employment specialist, they did have employment outcomes that were successful. So, but most of the clinicians didn't really talk to their clients about going to work, nor did they think that their clients could work full-time, or most of them didn't think they could work part-time. So work really wasn't being considered, and so they really weren't referring people to employment, and so therefore, because they didn't believe their clients could go to work, they really weren't referring them to employment, so their perceptions greatly impacted their practices. So without believing in that employment, they believed that employment was a good thing, but they didn't think their consumers could go to work. So trying to change that philosophy, we were hoping once we provided the training around IPS and started implementing IPS so that more people were going to work, we were hoping that we would change those thoughts and those practices. Because the research from previous efforts showed that it led to positive employment outcomes. So what we found, so then we implemented, we got a SAMHSA grant to assist at least 450 people to go to work over the next 5 years. We're actually starting year 4 at this point. So we used peer supports, we integrated the mental health with the employment team, and provided lots of training and tried to build up the infrastructure. So in integrating the employment team, and one of the sites really resisted this because their clinicians weren't meeting regularly, and they didn't see the need to change that practice of not meeting to staff cases because they were just too big. So through much, they finally agreed to do it, and so truly, as research showed, and it also showed in reality, that integration leads to lower dropout rates for the consumers. It also improved the communication between the clinicians as well as the consumers. One of the things that was interesting was having people go to work allowed the opportunity for the clinicians to really have those positive exchanges of information, and instead of just talking about symptoms, because the person was making changes in their life and was going to work, they were really able to bring back real examples to the clinicians to help them work through. Clinicians became more involved, which led to better treatment, and then the clinical information is incorporated in the employment plan. So when the employment specialists would meet with the consumers to kind of talk about work, they were able to bring some of those real things to the clinician, and the clinician was able to kind of say, well, yes, that job may be an opportunity, but it may not be a good fit given the nature of their disability. So they were really able to kind of talk through some of the strategies for positive outcomes. So just to kind of give you a sense, the integrated treatment team, what it can look like and what it does look like for our 2 sites, is that really you have the employment specialist, you have the VR counselor, but then you also have a peer specialist, a benefits specialist, housing supports, the psychiatrist is involved, the case managers are involved, the day treatment manager is involved. So you've got a lot of people around this person to be able to provide the supports that are needed. So depending upon what the issue is, if it's a workplace issue, the employment specialist may be able to intervene. But if it's a medication issue, the psychiatrist is able to adjust when the medications might be dispensed in order for the person to be able to go to work at a certain time. So the other integration has been part that VR and mental health now meet monthly, and VR has assigned a dedicated counselor to the project so that they meet monthly, but they pretty much talk weekly, if not daily, depending upon what's going on. So it really allows that integrated approach to ensure that all aspects can be addressed and that nothing really kind of gets, the ball doesn't get dropped because everybody is involved. And it really has been kind of one of those critical pieces for success on the project. So for my involvement and the center's involvement, we've been going in for the past 3 years conducting focus groups with the leadership teams of the 2 pilot sites, with the leadership with the VR and mental health agencies, and we've to kind of really figure out what's the stumbling block, what's still kind of the critical issue, kind of that readiness for systems change. We've also conducted consumer focus groups, trying to get their input about what's working, what's not working, and how they feel about going to work in their recovery efforts. I feel like I'm going really fast through this. I hope you guys are okay. So we also have done fidelity reviews. So a big piece of the IPS model is that adherence to the fidelity of the model is important. So we go in the beginning we went in every 6 months to conduct the fidelity reviews until the site reaches good fidelity, and then we go in there annually to continually assess how it's going and help them kind of problem solve what needs to get tweaked and what needs to change in order to meet fidelity. So in the beginning, some of that had to do with the integration of the treatment teams, trying to get leadership support, so as part of so that employment is part of the overall goals of the centers. Because in the past, if someone said they wanted to go to work, they just referred them to VR, and they really weren't involved in that process, and now that's totally changed how they operate. Another big stumbling block that we're still facing is strategies for sustainability. We're still trying to figure out how we're going to fund the IPS service once the grant period ends. And working with other states trying to get input, because the SAMHSA grant was awarded to 7 other states. And I'm not sure why my video is getting fuzzy. I'm sitting perfectly still, but my camera is not working. So hopefully you guys aren't looking at my video anyway, just focus on the PowerPoint. So we're working with 7 other states. All 7 states are funding it in different ways. And working with states that have been implementing IPS for a while, every state's funding system is so different. Pretty much if you figure out one state's funding system, you've pretty much only figured out one state's funding system because it doesn't transfer to other states because of the way the insurance is set up, access to Medicaid and Medicare for funding options is totally different in every state. And then the other piece that we're evaluating is the employment outcomes and really looking to make sure that the positions that are secured are individualized and that they're really achieving competitive integrated employment. So now looking at how people, so the focus groups we did this year, which was for year 3, trying to get a sense of, do people still have those same perceptions and practices regarding employment now that they've been implementing IPS for the past couple of years. So what we have found is that most of the clinicians and leadership now feel that employment is part of recovery, that the option of referring people to work really makes sense. People that had not worked in a long time, if ever, are now going to work. And so that those work outcomes are huge, and that the positive impact on the person and their families is well worth the effort that it takes in order to get somebody a job. A lot of the clinicians shared with us that the work really gives people hope again, and they really didn't have that beforehand. But people do need supports in the workplace to be successful, so that those job supports are a critical component of that. We had some confusion there for a while with the pilot sites because when they were talking about job coaching, they were comparing it to what is typically provided with the DD population, and so it's not that one-on-one hand-holding and doing the job with somebody, but really looking at doing job coaching differently. So some of the supports that people needed weren't being provided from that idea that they weren't supposed to be doing it, but truly trying to make sure that the job supports that are needed in order for that person to be successful needed to be in place. So they've had to kind of revisit that job coaching, job support role to make sure that they are available, because the one site was really spending all the time up front to find out what the person wanted, finding them a job, but then because they weren't providing support, they did not have a good retention rate. So really trying to revisit that. So when the person says they don't want anybody to know that they are receiving mental health services, but that also meant the job coach couldn't talk to the employer on their behalf to help the employer understand what was going on. So trying to revisit that with each individual to kind of figure out what level of disclosure was needed in order for that person to be successful. So that acknowledging that there was a mental health issue, maybe not disclosing the diagnosis, but more looking at what supports were needed in the workplace in order for them to be successful. The other big piece has been the integration of the employment team and the treatment teams. The impact has just been huge, and so we were able to participate in two of the focus groups at each of the pilot sites were the integrated team itself. So we had clinicians and employment specialists together. There was probably 15 people in the room just talking about the wonderful experience that they've had with IPS, the impact that it's had on the people that they work with, people that they didn't think would ever go to work. It's just totally transformed their lives. But the big concern that we have has to do with sustainability and finding funding. So I think these were the highlights of the focus groups we did this year. Hopefully, as we continue to work on it this year, figuring out how to use the braided funding, I think our big obstacle is really trying to find mental health dollars that are available to pay for employment supports and to pay for practitioners' time to build those relationships with the individuals with disabilities as well as with the businesses. Some states have found that money by closing down their community-based day treatment programs, in order to fund employment programs. But a lot of advocates and consumers are really nervous about that because that is how they spend their day, is going to those day treatment programs. So trying to find that balance of shutting things down and focusing on employment, but also ensuring that people's needs are met. For me, of course, I wish that we could increase funding so we could maintain both systems of the day programs as well as the employment programs so people would have options, but I'm not sure that an increase of funding is going to be available. But hopefully we can kind of do some advocacy with our legislators. The states that did the expanded Medicaid option, we did not in Alabama, and so the states that expanded Medicaid were able to provide the supports in the workplace such that it had a significant impact on people being able to go to work because they were able to get the supports that we needed. So I know there's some discussion with the healthcare of eliminating those options, but the expansion of Medicaid really allowed more people to go to work than previously were able to be employed. All right, so this is my Albert Einstein quote. So if you remember nothing from my presentation today, remember this quote: "We can't solve problems by using the same kind of thinking we used when we created them." And I think that's true for a lot of the disability service organizations that are out there, whether it's VR, DD, mental health, really trying to look at how the system operates in order to support people to reach their goals of employment and living as independently as possible. and that really does require some changing of how we do things, because we got here because of the systems that we have in place. And so really trying to make that systems change and those culture change within those adult agencies can really lead to more people having the opportunity to go to work and getting out of the life of poverty. I think I've ended faster than I thought, so I probably skimmed through too many things in the beginning quickly trying to get covered all of my slides. So we can open the floor for Q&A, and I can revisit areas if I went too quickly in the beginning. Are we still there?
Yes.
Hello.
I don't know whether, Leslie, you want to do the questions through the chat room or over the telephone? What's the easiest and best way to do that?
Christina, can you hear me? Can everyone hear me now?
Yes.
I feel like the guy on the phone. I unmuted everyone, and it seems when I do that, I mute my own. So you couldn't hear me. I was talking away. Yeah. So I've unmuted everyone's phone at this point. Just be aware of that no one put us on hold or anything. And does anyone have any questions?
I don't have any questions. Can you hear me?
Leslie, this is Jennifer. Dr. Fleming, when you did that survey for the practitioners, did you get a good response rate, or were they willing to fill out that survey for you?
Well, they were, but I think that the advantage I had was they were about to undertake implementing the IPS project. So I gave them a choice not to participate, but I'm not sure that their supervisors gave them a choice not to participate.
Okay, I understand that. I'm the employment specialist here at the center, and I also am the Work Incentives Planning Assistance Program Manager here. So we do the benefits counseling for the state. Unfortunately, we find that we don't have a lot of clients right now with serious mental illness, and just watching your presentation today put a lot of questions in my mind in how we can, increase employment options for that population here in West Virginia.
It really required an extensive training in the very beginning, trying to get the idea of zero exclusion so that if a person wants to go to work that they get referred. But of course, somebody has to start the conversation about work in order for them to say, yes, I want to go to work. And so we had the mental health agency change the application process so that there were multiple prompts to discuss work as an option for folks. So it really took champions at the local areas to kind of make those changes, policy changes as well as practice changes at the 2 mental health sites, soon to be 3, to really make sure that employment was part of the conversation, and that it wasn't just one conversation, it was multiple conversations. The other thing that we started doing is if someone just said an inkling of work, they referred them to the benefits specialist to really delve deep into that conversation about work and what it would mean to their benefits. So they really knew what they were getting themselves into to say, yes, I really want to go to work.
Yeah, we've been actually working with VR here in West Virginia. I've been working for many, many years on getting them to start benefits in counseling first, so that they can have successful outcomes with their work with folks who are coming through their system, because we're finding that a lot of folks will go through the VR system and then at the end have benefits counseling and decide that they're not going to work.
Yes.
Okay, thank you very much.
You're welcome. Thank you for listening.
Any other questions?
This is Kim Brown. I had a question.
Great.
Did I hear it that if a client was not completely abstaining from drugs or alcohol, they could still work if they were able to?
Yes.
Or be completely sober?
Yes, well, to be referred to IPS, they could still be using. Then depending upon what the job was, they still had to follow all the rules of the employer. But if you think about people that we all know, does anybody use alcohol and drugs and have a job? And
Correct.
for the most part, yes. So we were kind of we being the disability agencies, we're really setting a higher standard for our consumers. Now, illegal substance and using drugs in the workplace is still the law of the land, so that I'm not talking about that, but really that it's not a criterion not to be participatory. But oftentimes what happens is once they start participating in IPS and really start thinking about employment, oftentimes people are able to make that change to stop using in order to go to work. They have a reason not to use the alcohol or the drugs, and they have hope again. And so it does tend to happen that they're not using drugs when they go to work, but it's not a criterion for participation.
Perfect. Okay, thanks.
Any other questions? Christine, this is Leslie. I had a feasibility question, and that's just, your piece in and of itself was large, and then you're also presenting this multidisciplinary group. And so without having to relive all of that, that seems to be a logistical nightmare. Are you guys physically close to one another? What were some of the things that made that easy? What were some of the things that made it difficult if someone's trying to build that?
Well, definitely having the grant helped. Because it's still a grave concern. The focus groups, you could just tell. They love the IPS model. They think it would be such a disservice to people with serious mental illness to take it away, but they have no idea how we're going to fund it. So, and I don't mean I mean the state of Alabama. So yes, the grant was a huge factor in our ability to do this. The two pilot sites, one was near, if anybody knows Alabama, but one of the pilot sites was kind of north central Alabama near Birmingham, and one was in Mobile. So they're kind of at opposite ends of the state, but Montgomery and Auburn are kind of in the middle of the state, so it's like an hour and a half to Birmingham and 3 hours to Mobile. So not too bad of a logistical nightmare because it's just two sites. The third site that we're adding this year is in Montgomery, so you kind of have the southern, middle, and northern part of the state kind of. But I think the logistical nightmare is trying to expand it to more sites so that more people have access to the service. And that's going to take us several years to kind of figure out. I think trying to get the two agencies, mental health and VR, really having to take a leadership role to figure out how to do it. And a big part is the funding of it, so that for mental health, employment really hasn't been anything that they've paid for, funded in the state of Alabama. So that really is shifting priorities and shifting the money in order to make it doable. But doing the focus groups and the fidelity reviews, because you weren't doing it monthly, it did make it feasible. And it wasn't just me by myself. I had an evaluation team that did this with for the two pilot sites. And then part of the funding allowed the mental health agency to hire a dedicated IPS coordinator, and that person was able to weekly go to the two sites and provide the technical assistance and training that was needed. And then Dartmouth, who really the professors there really kind of started this IPS model and have really taken the lead in the research, have provided technical assistance and have established this large learning community that has representation from many states in the U.S. as well as other countries internationally. And so it's a large learning community that's constantly providing technical assistance and support. I don't think I included their website into the PowerPoint, I can send it to you, Leslie. Maybe you can share it with everybody else. But it's the IPS. If you Google IPS Center, they're now affiliated with Westat in D.C. And their website, even if you don't have, there's just wonderful. There's forms, there's protocols, the fidelity review form manual is there. There's just a wealth of information at their website to kind of bring these models to life.
That would be good. Yeah, I'd be happy to share that.
Okay.
And kind of related to that, my last question was, I know that at some point, and may still be going on, that our governors over time have had this standing workforce development group, and perhaps their agenda items have slightly changed, but we have had that focus on employment and increasing our employment, whether it's because we've been hit by, Kim kind of referenced the drug use issue and our workforce is declining, or we have an aging population. I mean, we have a lot of things toward that. Is that helpful? Is there a chance? You mentioned sustainability being the issue in the forefront of your all's minds at this point, and that makes sense because of the grant period.
Yeah.
But do you all have that infrastructure that you can tap into? Is that something that can be tapped into for this, but kind of have to increase awareness about your model and maybe have to capture cost-effectiveness data? Or, how does...
Yeah, we're hoping to be able to capture cost-benefit analysis information. But again, we're starting year 4, and we still don't have access to the Medicaid data to look at those hospitalization costs. I think if we could show our legislators that by going to work and participating in IPS led to reduced hospitalizations, I think that might help sway the legislators to increase the funding or to make funding available for the mental health agency. And I don't know about West Virginia, but in Alabama, our legislators don't care that there's research and documentation from other states having effectiveness with IPS. They really want to see how it's impacted Alabama. So we've got great personal anecdotal stories, but we just don't have that data story to show that this is that the cost to bring in and develop an IPS program and then implement it and then provide those services to folks leads to cost savings down the road. So we've got great quality of life stories, but I don't know that that'll get us increased funding until we can show. Other states have shown it. Nationally, the research is out there that the cost benefit of providing IPS is well worth the investment, because over time, the initial cost is high, but over time, because the person's going to work, there's a cost savings at the other end.
Mhm. Mhm. Well, those stories are successful. Yeah.
I'm sorry, say that again?
Well, I was just saying those stories are successful in their own right, so that'll be powerful.
Yes, hopefully so. We're hoping to get both in the next couple of years.
Great. Great. Well, are there any other questions for Dr. Fleming? Okay. Well, Dr. Fleming, thank you for joining us, and we really appreciate your presentation. I thought it was really, really informative, and it's always nice to have a model of what others are doing and learn from that experience. So I think you've given us that.
Well, thank you.